Okay, cool. All right. So during diastole of the ventricles is when we're going to fill them. So ventricle is relaxed. They are we're pulling on the chordae tendineae, we're pulling on mitral valve, tricuspid valve, so we see AV valves are open. 70% just drops in. The remaining 30% is as there is the atrial contraction or atrial systole. So ventricles, diastole, atrial systole, contract, pushing the remaining in. So that's ventricular filling. The next step is the atria are starting to relax technically. The ventricles are starting to contract. So as the ventricles start to contract, we release chordae tendineae. As we release chordae tendineae and we're building up pressure in there, the AV valves, tricuspid and mitral valve close. We're generating pressure now. The pressure has to exceed pulmonary artery and aorta. If it does not exceed that, all four valves are closed: tricuspid, mitral, aortic semilunar, pulmonary semilunar. Okay, all of those are closed. As pressure builds, and then pressure inside the ventricle becomes greater than that in the vessels, the aortic semilunar valve and pulmonary semilunar valve open, and that's our ejection phase. That's where we're pushing out. That's where we're increasing systemic blood pressure. Okay. Isovolumetric phase. This is after the ventricles have contracted and they're starting to relax. There is a period of time before they relax enough to pull on chordae tendineae and pull them open. So the semilunar valves have shut because the pressure in the aorta and the pulmonary artery are greater than inside the ventricles. So those doors are shut, and we haven't pulled the doors open from the atria. So there is a very small window where during filling everything is closed. Then we pull the chordae tendineae fully, tricuspid and mitral valve are pulled open, passive filling 70%, and then atrial systole, there's a remaining 30%. Fibrillation, fibrillation is just this erratic contraction. It's not in any I want to say symmetric. It's not in any appropriate pattern. When you look at the EKG, it's just erratic. So because of this, depending on where it's happened, we can see we can see two different things. So when you talk about AFib, atrial fibrillation, you see this all the time. It's not that big of a deal. They will live because 70% drops in passively. If they're losing some of that 30% because during AFib it's not pushing in, it's not that big of a deal. Their big risk factors are they can faint if they exert themselves a little too much, so they can have syncopal episodes, or they can form clots on the arterial side. This is one of the few times you see clots on the arterial side. So there's stagnation of the blood, they form clots. So this is why, like on AFib, they need to be on like something like Xarelto, or they will go in, do ablations if that's the causation. And they can also, I believe, put in pacemakers to control it. They can kill off the SA node and just put in a pacemaker, depending on the severity. But typically, you just give them something like Xarelto and move along. VFib is death. The pump, the primary portion of the pump, the ventricles, are not functioning. So you're not circulating blood to the lungs. You're not circulating blood to systemic system. This is death. Okay, immediately, not immediately, but you've got like a minute or two kind of thing. VFib is they are coding. Okay, VFib, they typically need to be shocked, and then they can use adenosine to restart the heart. But VFib, no bueno. Okay. This chart is it's great because it gives us a visual here. It shows us ventricular systole, ventricular diastole. So you'll notice the filling portion of the ventricles, the resting portion of the ventricles is much longer. So this is why if you start speeding up the heart, systole will take over diastole. That becomes a problem. Then we're in trouble. Okay, so this is the cardiac cycle. So we have a little math here we need to learn. I'll provide you guys with calculators during the exam. Okay. Ventricular systole is a constant. For it to contract the ventricles takes 0.3 seconds every time. Cardiac cycle, how we calculate it is it's over a minute. How many heartbeats do we have? So in this example here, a minute is 60 seconds. This person has a 75 beat per minute heart rate. So we divide 60 by 75. That tells us for one entire time of ventricular systole and ventricular diastole is 0.8 seconds. So we know this whole, jump back here. So we know this whole outer like reddish pink circle here is 0.8 seconds. And I'm telling you, this portion right here, ventricular systole, is 0.3. It's a fixed. So I have 0.8 is the whole circle. I'm saying 0.3 is a fixed. So that means the remaining is how much? 0.5. 0.5 seconds. Okay? So all you do is you take the total cardiac cycle, which is 0.8, that's what we calculated here, and subtract from it the constant, the fixed, the 0.3. And that gives you 0.5. That's the length of diastole. What gets wild is when you look at how I was talking the other day, like my situation of SVT, why SVT is so dangerous. You look at SVT, and my rate was 232. You start calculating it, it's not feasible. The math don't math, okay? There is no diastole, and that's why there is such a high risk of heart attack. All right, that's what makes it dangerous. So here we're saying diastole is when it reoxygenates the tissue. When the ventricles are resting, the pressure in the aorta is greater than in the left ventricle. So the door is shut. The aortic semilunar valve is shut. That's when there's a slight back pressure, and we pump it into left and right coronary arteries, circumflex, all of that, marginal artery, and we feed the heart tissue. So the faster you go and you decrease diastole, the more risk of injury to the heart. So here they give another example. They say, there's our constant, 0.3 for systole. Cardiac cycle, we're going to figure it out. This person is at 120 beats per minute. So we see here, when we divide, we get 0.5 for the total circle. And then we're saying 0.3 is systole. So we take 0.5, we subtract 0.3 from it, we get 0.2. Significantly lower. So if you're healthy, you have proper lung function, you have proper heart function, and you don't have blocked vessels, this isn't an issue. Why? Because you can circulate the blood fast enough, efficiently enough, the lungs can reoxygenate your blood appropriately enough, and you can deliver blood to the heart muscle, no problem. You start to make any of this wonky, you get into issues. If you have clogged vessels, well, now it's trying to push the blood past that and can't do it efficiently. The pipe is choked. So there's your coronary artery disease. If you have lung failure, well, you can't oxygenate, and the heart can have an MI. It can arrest. Or the output of the heart is decreased. How much I can circulate. Cardiac output is decreased. Then we run into issues. Okay. So when you talk about like athletes, the amount they can push out of their heart, very efficient. The amount their lungs can expand, very efficient. The layers of the lungs are very efficient at diffusing oxygen and carbon dioxide. And that's why they don't fatigue as they're, cycling or running for extended periods of time or playing basketball. They're healthy, and so they can live on that extreme, no problem. If I think about running, I start getting winded. But you'd be surprised at how quickly your body can adjust. So, for example, I think I told you guys I started working out and stuff the beginning of this year. That's been like my thing. Okay. So, this morning, literally just a little bit ago, there was a gentleman walking in front of me. He made it up the first half of a flight of stairs and he was winded. This is not good. Okay. Before, I used to go to like the full first flight and I started getting a little winded. Now I walked up the 3 flights, no problem. Like I said before, I'm talking about beginning of January. That's how easily I would get winded. So I am remodeling how my body functions in that short span of a time. It doesn't take a lot for you to increase ejection fraction or cardiac output, the efficiency of the heart. It doesn't take long to get your lungs used to expanding a little more. Okay? Maybe I cleared a vessel or two. Not really. All right. Isovolumetric contraction. This is where we are we are contracting the ventricles. All valves are closed, and eventually we build up enough pressure to open the semilunar valves. So you can see there's QRS, that's the electrical signal. There is the beginning of contraction. It's about halfway through. It's about at the R. And we're building pressure, and now the pressure inside the ventricles is greater than that in the aorta. This chart, they typically just refer, when you look at these, to just the systemic side. And then they do talk about the atria, but really they're just talking about systemic side, okay? So as we continue to contract, we reach equilibrium of pressure. Pressure in the aorta, pressure in the left ventricle are identical. Now pressure is falling in the ventricle, falling. Pressure in the aorta is greater. It slams the aortic semilunar valve shut. You can see the ventricle has already started to relax and is in full repolarization here. Pressure is dropping. It's filling. It's filling. It's filling. We send a P wave through. Atria contracts. We're pushing that remaining 30% in, and then we start the process over, beat after beat. Okay, so ventricles, when they're tightening down and the pressure then exceeds the aorta and pulmonary artery, then we eject out. It flows out almost immediately. The pressure is very rapid. Okay? Very, very rapid push of the blood into the vessels. And then from there, we start to go into relaxation, diastole, repolarization. So this image, there's actually a better one. I think it's this one. This image is really great because you're trying to learn all these different concepts and then you're trying to build it all together. This is what it's doing. It's building all of it together at once. So you're seeing all of it. So here, passive filling, just ventricular filling. Atrial contraction, this is the remaining 30%. There's P wave. There is atrial systole. Here is end diastolic volume. End diastolic volume is referring to the ventricle. At the end of rest, how much blood is in there? That's what we're saying. It's full. Here we're starting to contract ventricles. Everything's closed. So we're building pressure, building pressure. There's QRS. Because we closed the mitral valve and the tricuspid valve, there's our first heart sound or lub. Now the pressure inside the ventricles is greater than that inside the aorta and pulmonary artery. Look at the volume of blood inside of it. It's gone. This is end systolic volume. At the end of ventricular contraction, we've dumped out pretty much everything. That's the goal. The difference between these two is referred to as stroke volume. Stroke volume is how much I pushed out. Well, how do you figure that out? You look at what you started with, you look what you ended with in there. The difference between the two is how much you pushed out. Okay? Because the pressure now in the aorta and pulmonary semilunar valves, or in the pulmonary artery, are greater than in the ventricles, we slam shut the doors. There's T wave, there's repolarization, relaxation of the ventricle, there's the drop in pressure, and we start the cycle all over again. Okay? Abnormal heart sounds, it just depends. Some are considered normal early in life. As you get older, they would be considered abnormal. And there's different reasons for them. So really, you just talk about lub and dub. And then outside of that, I think S3 is considered normal depending on age. Anything between that, after that, is alterations. Okay, so for example, S1, S2. Between the two represents ventricular systole, right? So this means during the ventricle contraction, if we hear something, it's during systole. So one example is you'll hear nothing, and then all of a sudden you hear big sound that shrinks. That's a murmur you can hear. And what that is aortic stenosis. Think about it. It's building pressure, building pressure, building pressure. All of a sudden, doors open, and it shoots out and reduces as the volume of blood is lessened. So when we listen to the heart, we hear lub, dub. We can tell that. Okay, so, but heart sounds, it takes a while to get good at heart sounds. I remember my first rotation was peds, and my preceptor was like, during her residency, it took her the whole first year to be able to hear children murmurs. I mean, she would call me over when there was a child with murmur, and I had good stethoscope, Littman, and I would listen and can't hear it. One trick I did learn to hearing heart sounds better: close your eyes. When you take away a sense, your brain focuses on the other senses. I don't know if you ever heard, like, blind people will hear a lot of things compared to people that can see. And it's really, that's the reasoning. So when you close your eyes, that can help you focus on sound more. And don't get one of the fancy electronic stethoscopes. They won't let you use it in school. Okay. So calculation here. End diastolic volume is how much it is in the ventricle at the end of rest. So we passively opened, we dropped 70%, atria contracted, there's remaining 30%, we are full. And end systolic volume is at the end of the contraction. The difference between the two is, what did I start with? What did I end with? That is stroke volume. One stroke of the pump. That's what we're saying. Okay? Like old school, or not old school motors, but like you talk about like 4-stroke, 2-stroke motors, like what's in your weed whacker, that kind of thing. It's how many times they're doing the pump. That's what that is. So stroke volume is how much the heart pushes out every time the ventricles contract. That's the difference you're calculating there. So here they started with 130 mLs, and the stroke volume was 70. So here they're trying to calculate end systolic volume, what was remaining. So we're saying you started with 130, you pumped out 70, what's left over? 60. Okay? Cardiac output. Cardiac output is how much is that pump pumping out every time it contracts over a minute. That's all it is. Don't freak out by these equations. Put it in words you understand. We know every time this pump contracts, we said 70 mLs from the last slide. And we're saying this person's heartbeat is 72 times per minute. So we calculate it. There is something that you're going to get hung up on here. You notice the measurements. They're in mLs and they switch to liters. How many mLs is 5 liters? 5,000. There is 1,000 mLs per liter. I know we don't we don't use that equation here, right? Okay, the math is mathing, I promise you. Um, so yeah, be mindful of that when you guys are doing like homework and stuff. I always get an email from a student. I put in the right answer. I don't know why. I calculated correctly. I used your PowerPoint. It's the units. That's what it is. They're catching you on the units. So be mindful of units on the exam. If it's short answer, you need to put the units. You need to put the correct units. If you just put 5 there, I don't know what 5 is. 5 liters, 5 gallons, 5 feet. Okay. So units are important. So think about it like this. Don't even look at this. If I have a pump that's pumping out a certain amount every cycle, how can I make it pump out more? More pressure. If I put more pressure, I'm putting more volume in there. So we're going to talk about something called preload. Preload is how much blood is returning to the heart, into the atria, then into the ventricles. How can I increase preload? How can I make more blood come back into my heart? How can I increase my blood volume? How about that one? Natalie, increasing venous return. So when we do things like squat and you squeeze your legs, you squeeze the veins, you squeeze more back to your heart. There's actually a phenomena seen in this heart defect that children are born with. It's called tetralogy of Fallot. They have 4 defects in their heart and they don't oxygenate well. And so something the kids will naturally do is squat. They'll go into what are called like TET spells. Their upper body will turn blue. And so we have to correct it. But yeah, squatting, for example. How can I increase blood volume? Because if I increase blood volume, in general, I should, if I maintain heart rate, pump out more. How can you increase blood volume? Hint, hint. Is that going to increase the amount of fluid in my system? It's not going to increase the amount of fluid in my system. How can I increase the fluid in my system? Drinking more water. Fluids. If you put more fluid into this closed loop system, there is more volume. There is potentially more returning to the heart, more I can push out. So when you put an IV in a patient and you give them fluid, there's more blood capacity. You give them blood, more blood capacity, more efficiency of the heart. How else can I increase how much is coming out of the heart per minute? Huh? Moving, exercising, increasing. What am I increasing when I exercise? Heart rate. Okay? Increasing heart rate. The contractility portion there is a technicality there. When we vasoconstrict, the amount the blood has to sit in, the amount of space in the vessels reduces. So initially, it's going to increase what's called afterload, how much pressure I need to exceed to get out of the heart. But it's a closed loop system. I will return more and eventually increase the efficiency of the heart and how much I'm pumping. Okay? So here, if we increase heart rate, the amount I'm pumping out is the same, but now I'm pumping out faster. So if I double it, I'm going to double the amount of cardiac output per minute, right? Because cardiac output is nothing but rate of heart times the amount stroke volume. So how much I'm pumping out. So if I move my hand twice as fast, I should be pumping out twice the volume. Increase stroke volume. If we put more into the heart, more will come out of the heart. So cardiac reserve is talking about how high you can go above resting heart rate. The higher you can go, the more activity you technically can do. Usually the limiting rate step here is age. If you're a healthy individual, age, the heart's only going to go so fast. As we get older, it slows down. Every year, it's one less achievable rate, one less heartbeat per minute that you can do. Now, that being said, you look at athletes can exceed that, okay? Athletes can exceed that. Frank Starling law is simple. Keep it simple. If I put more in the heart, more will pump out. How do I put more in the heart? I return more to the heart. So this is preload. The more I have a slingshot, if you ever use the slingshot, okay? I don't know if you have, but if you ever use the slingshot, or if, okay, how about when you were a kid and you used to do the little, you take the rubber band and you fold the paper on it and you shoot it across the room? You shoot the teacher. I was that bad kid in middle school. Spitballs. It was innocent fun, okay? But those little guys, and you pull back. If you pull back a little, how much energy or distance do you get out of it? Not much. The more you pull it back, the more energy and distance you get out of it. That's preload. The more we put in the heart and the more we stretch the heart, the more we're going to get out of it. The more efficiency in the stroke volume, the more we pump out, increasing cardiac output. Okay? So you look at like these athletes, the contractility or the relaxation of the heart, they can relax it way more. Their muscle will stretch more. So there's more preload. So how much they pump out of their heart, the efficiency of what they pump out in stroke volume is much greater. So what do you think happens to their heart rate? Do they have the same heart rate as like you and I? These extreme like athletes, professionals? Mm-mm. You look at people that have very high stroke volumes, the heart rate decreases because they can maintain blood pressure. I mean, just out of curiosity, I bet you it's like public information. Let's look up LeBron James resting heart rate. He's a big athlete, big guy. James resting heart rate. Hold on. If this is right, this is pretty wild. Where'd it go? Man, this is a horrible article. Okay, well, here's someone else. It's easier to find. Some biathlete, professional biathlete, his resting heart rate is 25. That's wild. I mean, you look at like us, we're going to be somewhere between 70 and 100. Okay. And then as we work out, it's going to jump up a lot. So, yeah, so here, yeah, so LeBron James, for example, when he's training, he's somewhere between 85 and 90. His training is our resting heart rate because efficiency of the heart. Like you look at us when we're like training out pretty hard. For me, I was looking at it this morning and I was like in the beginning, I would hit like 160s. Now I'm in the 130s. I'm not doing anything crazy. I'm probably not doing anywhere near the intensity he is. But that just shows you how efficient his heart is at stroke volume. Okay? So preload is the how much you put in. It's how much you pull back on the slingshot. Afterload is the amount of force it takes to push out into the aorta and pulmonary artery. What's going to increase afterload? What's going to increase the force to push out? Amount of fluid inside where? That would increase preload. It should decrease It should be easier technically to push out. What's on the other side of the doors? What's on the other side of the valves that would fight back at you? Why would the pressure inside the aorta or so what about the arteries? There's pressure. So what would a patient come in with where you would start to suspect that they have afterload issues? Don't overthink it. What about their pressure? Correct. High blood pressure. If they have high blood pressure, what's the causation of high blood pressure? The vessels have hardened. You put too much pressure in it, it's a rubber band. Eventually, it fights back against the pressure. There's muscle in those arteries, so they stiffen. That's going to increase blood pressure. Cholesterol building up in the walls, going to increase blood pressure. Viscosity of the blood increasing, increased afterload. Volume of blood. Think about it. It's a closed loop system. If I've got to push it a mile through the body to come back a mile versus 2 miles, that's a whole lot more of stuff I got to push. So as we gain weight, more vessels, more pressure to push against. All of those will increase afterload. The heart is a muscle. What's going to happen to the muscle? If you work out a muscle, what happens to it? It gets stronger. Why does it get stronger? Does it maintain the same size? You put more actin and myosin in there. Really more actin, I believe, not necessarily myosin. So what happens to the size of it? It increases. We're limited on space here. So when a muscle starts to increase in size with the heart, it grows in towards the ventricle. Will your stroke volume remain the same? Can you put as much in? If the ventricle is shrinking, can you put as much in? You can't. So what's going to happen to cardiac output? Is it going to go up or down? It's going to go down. I can only put so much in there. I'm going to contract and only push so much out. So how's the heart going to respond? It needs to maintain blood pressure. How do you maintain cardiac output? If I can only put so much in, I need so much out. How can the heart respond to maintain blood pressure? Making you think today. What about the contractions? It's limited though on space, so it can't push more out per time. How can we increase cardiac output? Cardiac output is stroke volume times heart rate. So if I'm limiting stroke volume, I'm shrinking that. How can I maintain that cardiac output? Increase your heart rate. Now the heart is working harder. The oxygen demand is higher. So the risk of heart issues, heart death, muscle death increases. Okay? We're being kind of sold something with society lately that obesity is fine, that you can be healthy with obesity. It's ticking time bomb. I always tell students, you ever seen someone in an old person's home, for lack of better terms, an elderly facility that is morbidly obese? Mm-mm. There was a comedian I was watching, and he very heavy set guy, and he was on stage, and he's just talking about it. He's like, "Yeah, I'm this big." He was probably 400 pounds or so. I forget his name, and he's like, "I'm healthy. I went to the doctor. Everything's fine." He died like 6 months later or a year later, and I guarantee you, it was a heart attack in the end. The heart muscle just gave up or arrested, stopped, just stopped. They said, "I'm not working anymore." Okay, so For heart health, the more we work it out, the more it stretches, more preload we can do, more we can put in there. The efficiency of it, it doesn't have to work as hard. Okay? If we increase afterload, it has to work harder. That's congestive heart failure. Congestive heart failure, we're also seeing it for another reason. The other side of the heart. Where does the right ventricle have to push through? Which vessel? Pulmonary. When you expand your lungs, you compress the capillaries. You increase the back pressure. The right ventricle has to work harder against it. That's COPD. Chronic obstructive pulmonary disease. Those big old barrel chest guys, the reason they're doing that, they lose the elasticity in the lungs. It can't contract back down, and it hyperinflates bigger and bigger and bigger, compresses it. So they end up with right ventricle heart failure or right-sided heart failure. Okay. Pulmonary fibrosis, same thing. Pulmonary edema, all of these. When there is a severe lung issue, it leads to right ventricle issue. So when someone smokes, it's not just worry about cancer, it's worry about congestive heart failure on the right side. As they destroy the lung tissue, they are destroying their heart. Okay? So preload, venous return, how much we're bringing back to the blood. Afterload, how much it takes to get out of the heart. So hypertension, lung diseases, all of those are going to destroy the muscle tissue simply because they're making it too big. Stenosis, if the valves harden, it's harder to get out, can lead to heart failure. So when you talk about like diseases like endocarditis, where they get infections in the heart, rheumatoid fever, where they have like an aseptic autoimmune response and it destroys the valves of the heart, it causes stenosis. The heart has to work harder. Okay. Autonomic regulation, flight or fight, I need the heart rate to increase cardiac output, to meet the demand of the tissue. Breathing is also going to increase. A person should maintain oxygen level as they increase activity. So if I start running, if my heart is in good health and my lungs are in good health and my vessels are in good health, I should maintain full oxygen saturation. If it bumps down, it's ever so slight. We shouldn't see it drop down significantly. Parasympathetic, rest and digest. It's a muscle. The body is lazy. It doesn't need to work obnoxiously fast if I'm just laying there. The oxygen demand of the tissue is low, so the heart rate should slow. The breathing rate should slow. And then regulation center, medulla oblongata. Okay. Chronotropic, chrono is time. So it's speed of the heart. That's what it's saying. It's time. How many beats per minute is what we're talking about. So if you give a drug that is a positive chronotrope, it increases the heart rate. If it's a negative chronotrope, it slows it down. So when we talk about like giving a patient epi, you give them epinephrine, their heart rate is going to go very fast. If you give a patient beta blockers, it slows it down. We regulate the speed of the heart. Inotropic is force of contractility. The harder the muscle contracts, the more the oxygen demand. So when we're like running and we give a patient epi, it's going to contract greater, faster. So we're going to have increased stroke volume, increased cardiac output. Versus negative inotropes, those decrease the force of the contraction. It's not as hard of a contraction. So this is the calcium channel blockers, like nifedipine, stuff like that. They decrease the contractility of the heart. The heart doesn't have to work as hard. The demand for oxygen is less. Better for the heart. Okay. Dilazetam. Yeah. So my dad is on that. Funny story. This is why you pay attention to your meds. And my mom fills my dad. Okay. My mom fills like the little pill dispenser, the daily one for him, because otherwise he's not going to take his meds. I can relate, right? So my mom goes to fill his pills one day and she's like, "Why does this look different?" She sends it to my wife and they misfilled it and put diazepam, which is like a benzodiazepine. It's a benzo. Why am I blanking? Okay. Not gonna work for him. They misfilled it. That's a big no-no. Right? So just be mindful. Look at your meds. Mistakes happen. That's a big mistake though. That's someone's gonna get in trouble. Mistake. Right. Epinephrine, like we said, increased force of contraction, increases rate of heart. So it really elevates cardiac output. So how do we increase stroke volume? We walk through these, increase venous return. So like squatting. There is some ability to contract veins. There is a little bit of tunica media in there. They can constrict down a bit. Increase sympathetic nervous system, so rate of heart rate, increase it, and also contractility. So who does that? Epinephrine, norepinephrine. Calcium increases that contraction force. So that's why we give calcium channel blockers for patients that have had heart issues, so the heart isn't working as hard. We went through these. Make sure you go through them. So there's a little statement down here. Increased afterload will initially decrease cardiac output. If you put an IV into a patient, initially there is more afterload. Eventually the veins will accommodate it. It will then increase the return. Really, that's a bad example because we inject IV into veins. So really that's increasing directly preload. A good example would be constriction of peripheral blood vessels. It's cold out. So you're going to constrict all your arterioles. That's going to increase afterload. But eventually what's going to happen, more blood is going to cycle through and it will equalize and increase preload and match the afterload. So it's not a problem. All right. So if I increase afterload, what should that do? Potassium, here we go. Just load them all. Oops. Okay. So for the first one, if I increase afterload, I should see an initial decrease in cardiac output, and then eventually it should normalize. But if we're talking about like in the situation of things like high blood pressure, it's sustained afterload. Eventually the heart starts to accommodate for it by building more muscle. That's not good. Increased potassium. The problem with this is potassium is when we repolarize. If you put more potassium in here, the potassium cannot escape easily. So heart rate should decrease. We're staying up here longer before we come back down. You put too much, we just stay up here. Tetany. Adrenaline, that's epinephrine, norepinephrine. It should increase rate and contraction. Calcium, increase force of contraction, how much that tightens down. So that increases stroke volume. That increases cardiac output. Parasympathetic, rest and digest, heart slows down. We don't need to maintain a high output. Increase preload, I'm putting more into the heart, so more will leave the heart. The more you put in, the greater the stroke volume. So cardiac output will increase even if I don't increase heart rate. Thyroid hormone. It increases metabolic activity. It increases heart rate. So when people are on Synthroid, we're dosing it in micrograms, not milligrams. Minute amounts. Too much, they can actually go into a like thyroid crisis essentially, and they can have arrhythmias of the heart. So taking too much Synthroid is very, very dangerous. Okay. So we talked about this the other day as well. Right congestive heart failure. Where does the blood come from? That's where we get the accumulation. Okay. So right ventricle, the blood comes from right atria. Where does the blood come in from into the right atria? It's draining from superior vena cava, inferior vena cava. It's the venous side. So it's systemic. So we see edema in the tissue. Left congestive heart failure. Where is the blood coming from? Left ventricle, left atria, pulmonary veins, the lungs. So we see pulmonary edema. So this is just images showing that. The formulas we talked about, make sure you guys go through that. And remember with the formulas, put them into like your own words. It'll be much easier. Okay, like where is that blood? What is it doing? All right, let's pull up the next one. Okay, blood vessels. So we're going to run through all these areas. You guys go through them specifically like in lab. Remember right and left of patient with them. You know, when it's on midterm, if they ask a vessel, you better put right and left. Because on our keys, it's going to ask that. You guys need to know that. It's always patients right and left. So arteries are always away from the heart. Veins are always back to the heart. And capillaries are where we actually exchange nutrition with the tissue. So when you look at the pressures, you're coming off like aorta, you know, very high pressure. And as we cross, we see a big drop at the arterioles. So between arteries and arterioles, big major drop because these guys can expand and contract significantly. Then as we cross over through the capillaries into the venous side, we see on the way back, there's like no pressure whatsoever. Low pressure. Like when you talk about like IVC, SVC, they'll say it might be like 2-3 millimeters of mercury returning to the heart. Such low pressure, but they're big old vessels. That's why we're losing all the pressure. As far as the tissues go, they are similar in that they both have tunica intima, tunica media, tunica externa. The big difference here is tunica media in the artery, very thick to withstand the pressure. Tunica media in the vein, very small. Okay. The endothelium, that's where you see this elastic tissue. And then you'll see in arteries, they have a secondary elastic tissue, the external elastic tissue. Okay, so we have internal and external. In the arteries, there is elastic tissue kind of wedged in between when you look at the vein. Correct. Arteries do not have valves. Now, are there valves on the arterial side? Yes, like aortic semilunar valve. But in the vessels themselves, arteries do not have valves. The reason we have valves in veins is to help with return. So like in your legs, for example, when you squeeze that muscle, it helps push the blood up the escalator system so it can return to your heart. So, artery, vein, thick old tunica media to withstand pressure. Arteries are always open, round, veins very large, and they can be collapsed down and whatnot. When vessels are really big, whether they're arteries or veins, they have what's called vasa vasorum. There are tiny little capillaries that are feeding the outside of it, because the inside, there's oxygenated blood. It's feeding a certain depth of the tissue, but it can't make it all the way through because of how thick tunica media is. So on the outside here, there would be capillaries feeding from the outside in. So that's vasa vasorum. Arterioles, this is where we're getting smaller. They are thinner because we're distributing pressure. So as you go from one vessel to two vessels, you drop the pressure 50%. You go so on and so on. It drops as you split it. These guys, though, because they can change their size significantly, this is where we drop pressure significantly, or where we can really increase afterload and then increase preload by getting the blood out of there. So they help regulate blood pressure. So when you look at them, they're wrapped in smooth muscle. That's what's going to help them contract, and then as it relaxes, allow the pressure to drop. We'll also see their effect before, like capillary beds, whether we want the blood going through there or not, they can have an effect on that. The medulla controls the blood vessels. So if the blood vessels increase blood pressure, so the blood vessels contract down, you increase blood pressure, you can see a drop in heart rate, or vice versa. If they dilate, you can see an increase in heart rate. So when you're talking about like when you're working out and stuff, we typically flush. One, because we're trying to get rid of heat. Two, because we're dilating vessels to feed the muscle tissue that is requiring the oxygen because it's working harder. So we should see heart rate go up. So as we get older, we see this phenomena as well. Our vessels start to harden. If we don't like work out, stuff like that, the vessels start to harden. So as they harden, blood pressure increases. So that's why as we age, we tend to see, especially in the older population, like blood pressure climbing, climbing, climbing. You should see heart rate dropping, dropping, dropping as in response. Eventually, the heart rate's not going to really want to drop much. And then we see the blood pressure climbing, climbing, climbing even more. Okay. So as you work out, you keep that ability of these vessels to dilate, contract properly, and that's why you see, older people that can maintain proper heart rate is really due to health of the whole cardiovascular system. When we look at the capillaries, so the first one we talk about is continuous. This really isn't allowing tons of migration of fluid or perfusion of the tissue. Some, but not tons. So you're going to see it in areas where you don't want, like, essentially blood volume leaking too readily. So like in your skin. Yeah, we want some nutrition, but not too much because it's near the surface. Fenestrated, we talked about fenestrated in the liver. Um, wait, no, not the liver. That's the next one. Okay. Fenestrated kidney and small intestine, because we want nutrition to come in. We don't really want cells to leave, potentially. So that's where we're seeing fenestrated. Next one is sinusoidal. This is the one in the liver. Here, we want cells potentially to pass through. So as you're filtering like your blood, we want cells to be able to pass through there. The hepatocytes can deal with it. Bone marrow, because you make cells in there and you want them to get out. So that's why you're seeing in there. Spleen, we're filtering the blood. We're looking for organisms in the blood. So that's why it's sinusoidal. Capillary beds. So this is where we're seeing a lot of capillaries kind of spread out. And this is where we're going to see tissue nutrition happen at. So we have beds all throughout our body, or all throughout the tissue, except for a couple areas. The cornea of your eye, the center of your eye, you do not have capillaries there. Your eye is oxygenated by the air. Back in the day, they used to have glass contacts. Now modern contacts are gas permeable. They're gas permeable because with the glass contacts, what can happen is no oxygen to the eye, and they can actually have neovascularization. They would grow vessels. And I remember even with like these plastic contacts, whatever they're made of from now, I remember they used to say still you shouldn't wear them 24 hours a day. You should be taking them out and let your eye breathe to prevent that potential neovascularization. Because if that happens, you're not going to see. Same with the lens of the eye, because light needs to pass through there. Epithelium, when you think about it, a lot of it is dead or sloughing off. So we don't want blood vessels right at the surface. And then cartilage. If I have between my joints, like in my knee, for example, if I had capillaries and I jump and land and that cartilage taps, it would bleed profusely. That's why like you pierce your ears and stuff. It does not bleed profusely. Simultaneously, it doesn't heal very well. If there's not blood supply, it doesn't want to heal too well. All right, so blood flow through the capillaries. There are what are called precapillary sphincters. If the tissue isn't working, you're resting, the sphincters are going to tighten down. There's no need to circulate tons of blood through there. Just a little bit will filter through, not too much. Or you're cold. I don't want to lose heat. They will tighten down. Now, if the cells are undergoing cellular respiration at a high rate, the byproducts of cellular respiration are CO2, hydrogen ion, heat. So what does that mean? The tissue's working. If the tissue's working, it needs blood. So we'll open up the sphincters, let the blood rush through. So that's why like when you're working out, you may flush. That's part of the reason. You're working. Sphincters are dilating. Simultaneously, it is so to get rid of heat. We bring the core blood towards the surface, we get rid of heat. When we're cold, we want to pull the blood in towards the core so we don't radiate out heat. Okay. So here they're showing there's those precapillary sphincters, and then they're dilated here. We're allowing the blood to flow through. Here they are constricted, not a lot of blood flowing through, just kind of right through the center here. So this would be like you're working. This is rest and digest. There's an interesting phenomena before we leave here. People that get trapped out in the cold and they die out in the winter time, stuff like that, trapped outside, they tend to find them naked, which is kind of wild. And the reason is when they're out in the cold, initially their body is doing this. When their body fatigues and they can't hold the sphincter shut anymore, they'll open and they feel like they're on fire. And that's why they strip down. It's kind of crazy. It's kind of wild. Thought that was neat. Venules, so these are thinner. They're kind of the counterpart to arterioles. Because we're on venous side, you'll notice tunica media is thin, pressure is dropped, and we're heading into direct veins. So this is deoxygenated blood. So veins, like we looked at, they have the 3 layers. It's just the media is thinner. They can have vasa vasorum. So the big thing with veins is they're a reservoir for blood. I mean, you look at the size of the vein versus the artery, there's tons of blood in there. They still have tunica media. It's just not hugely thick because they're so big, blood pressure is so dropped, they don't need it. So when we need to increase preload for some reason, we need more blood coming out of our heart, we need more cardiac output, more stroke volume, the veins can constrict down. We then return more to right atria. We return more to right ventricle, more to lungs, more to left atria, left ventricle, and out. stroke volume is increased. Okay? So they're increasing preload. So this is that last point down there. You'll notice like when you stand all day, stuff like that, your legs tend to swell. That's because the pressure in the veins is increasing and you are creating a bit of edema. That's normal. Put your legs up, they drain. Injure your leg, what do they tell you to do? Don't stand on it. And what else should you do? Keep it elevated. So a lot of times when there's injury to certain things, we say keep it elevated. There's already a lot of pressure in there because of the inflammation. We don't need more because it's not draining. So you elevate it. When I had my knee surgery, ooh, I put down my leg for just a few minutes and you could see it start to swell. My ankle would just start to swell. So like half the time I'm teaching class, every time I'm teaching class, I literally would be in here and I would be sitting like this and I would have a chair and I'm just sitting here teaching. I didn't have a choice. It was incredibly painful, incredibly painful. Okay. And then I went on a plane. Oh, when you go when you go up in the atmosphere, pressure drops. And as we took off and you just climbing up, you literally could see my legs slowly growing. I could feel my pants getting tighter and tighter and tighter. That was very painful. There was some painkillers taken. I promise. It was a rough situation, okay? All right, so we have valves. The valves help move the blood up. As we squeeze the muscle, we pump it up higher and higher and higher. The problem is the valves can be destroyed. Obesity, pregnancy in two parts. One, because of the increase in plasma volume that a woman has, and then also the compression of, I want to say it's the femoral vein through the inguinal canal because of the fetus. It compresses it, or the uterus, whichever way you want to go with it. Okay, there is compression there, and so they develop varicose veins, standing all day, not moving around, and then hereditary. Some people, if they have them in their family, a good chance they're going to have them. And smoking is another causation, high blood pressure, anything that's going to increase the volume of blood or the pressure in there. So valves, this is in the veins, so it doesn't flow back, and so we can move it up. How do we move it up? Skeletal muscle, milking. Okay, it's squeezing the vein, moving it up the elevator system. Breathing, breathing can increase return as well. Okay. Venous sinus, that's just, we talked about this, the draining from the heart, returning. Portal system. Portal system is when you have a vein between two capillary beds. So if we think about it, we looked at the intestines, we absorb nutrition, we send it through a vein, and where does it go? It goes to capillaries, but what organ? After you absorb nutrition in your intestines, what organ does it go to next? Liver. In the liver, capillaries. Okay? That's a portal system. So anytime you see capillary, vein, capillary, portal system. Arteriovenal anastomosis. So we have normal ones. This is where two arterioles are connected, and we don't go to the venous side. Okay, no capillary bed. So circle of Willis in the brain. It's to help with oxygenation of the tissue. Palmar arch. There's one in your foot, and then we sometimes have what are called AVMs. These are malformations. That's not good. When you have a malformation, you can see it in different situations, like people get stabbed or shot. You can see AVMs form, or when we put in ports for dialysis, we create an AVM or anastomosis, and that's where they plug in. Special circulations. We went through this, so you guys should be comfortable with this. This is circulation of heart around the body, back to the heart. That's what they're talking about. Okay. We went through this. This is pulmonary, lungs, back to left atria, oxygenated. Coronary circulation, we touched on it a little bit. Okay, so out the aorta, left and right coronary arteries, through the branches. Now we're on the venous side, through the coronary sinus and into right atrium as deoxygenated blood. And we'll stop here. Any questions? We made good progress. Right? We have another date. Just hold the thought for a second. Is open lab at law or today at law? I believe so. I don't think we have any A&F hours today. Yeah, we don't have any A&F. But the hours should be posted on Blackboard just to confirm. Yeah, we have another day to cover blood vessels and lymphatics. We'll be fine. We're good. We're at a good point. All right. Study, people, and I will see you on Monday. Bye.